And we thank him very much for organizing it, because it's a topic I think that a lot of people struggle with.
Yes, me.
Should we give it a few more minutes until everyone gets it? Do you mind?
Yeah, I think we should do. We have 19 in total. Should we start, Shahin?
Sure, yes, I'm happy.
Yeah.
Okay, nice to see you all. My name is Shahin Hajibandeh. I'm one of the general surgical trainee and HPV trainees in Queen Elizabeth Hospital, Birmingham. So I'm just going to put the camera off. I just want to say hi to you before putting that off, and then I'll proceed with the presentation. Ahmed, could you please confirm that you have my screen?
Yes.
Sure. Today we are going to talk about a systematic review and meta-analysis. I know that the main purpose of the meeting is to learn how to do publication, and I'm just going to share my experience with you with regards to systematic review and meta-analyses and the way that you can publish them, because I believe that they are the easiest to publish if you just do them step by step. So I'm sure most of you have seen this diagram before. So this is a level of evidence diagram where you can see the hierarchy of the level of evidence increasing in terms of the quality as you move up towards the top. So any study design which is mentioned here, the outcome of which can be published, and there are different ways of entering into the research. What I'm going to talk about today is mainly meta-analysis. And as you can see, the meta-analysis usually provides the highest level of evidence in any topic in medicine or surgery. And it is a study of the comparative studies, means that you compare a treatment A with treatment B, or a treatment A with no treatment. So in theory, it is a study of the comparative studies. And as you can see, there are different study designs here. And of these designs, I can just introduce to you a randomized control trial, cohort studies, and case control studies, which are the comparative studies, the original comparative studies that usually compare a treatment with another treatment. And in a theory, you can include all these studies, case control, cohort study, and randomized control trial, into the meta-analysis. And an ideal meta-analysis is an analysis of the randomized control trial, but sometimes in some topics there is no randomized control trial, in which case you can include observational studies as well. So I would like you to concentrate on this point I'm going to mention, because there are different ways of entering into the research and doing the publication. You can enter research in an uncontrolled way, meaning that you can go into one of these study designs or randomized control trials, cohort studies, or sometimes case control studies. And usually you may be introduced by some collaborative team that you need to take part in this study design. And you need to do data collection, and then once your data collection is complete, they say that your name will be published in a paper, which is absolutely right. And also you have been involved in the randomized control trial or cohort study. So of course the process is very long, and you will never be a primary investigator in those studies. And don't get me wrong, these are very high quality studies, and even a small participation into these studies can enhance your CV. Nevertheless, it doesn't necessarily give you the satisfactory publication that you are looking for. So although I usually believe that people should not run before learning how to walk, I started this myself by doing a meta-analysis, because I got some reasons behind that why to do meta-analysis. First of all, it will provide the highest level of evidence in any topic that you're going to investigate, even more than randomized control trial, because you include several randomized control trials if there are several randomized control trials in the topic that you're meta-analyzing. And also it's a level 1A evidence. It's a research. You can publish it. You can do the presentation on it, you can teach on it, and also that is something that helps you to improve your critical appraisal skills, knowing the details of these studies, and then when you become a established researcher with good publication history, then you can design your randomized control trial and cohort study. I would call it a controlled way of entering the research. There is no right and wrong, but I believe that is the easiest way for people to improve their CV in terms of publications, and also whatever they do is a high quality evidence and easy to publish compared to, for example, a case report, which is level 5 evidence, but you have to do lots of things to publish it. You need to pay for it to be published. You need to take the patient consent. You need to ask a consultant for a specific details of the operation to make that interestingly. And not only that, but also the most leading journals do not accept case reports anymore. So my first recommendation is to proceed with a meta-analysis if you would like to consider a publication. In order to do a publication, there is a specific the guideline called PRISMA, Preferred Reporting Items for Systematic Review and Meta-Analysis, that usually consists of 27 checklist items. So I go back for example, when you read through that, the first line makes sense to you, second line makes sense to you, makes sense, then start to they don't make sense anymore for you. Okay, so and what I usually recommend when I do teaching on meta-analysis, I say, don't worry about this diagram, do a meta-analysis yourself under supervision of a person who knows how to do meta-analysis. Once your study is ready to be submitted, then take a look at this, and then you see you have done all of these steps, and then not only that, but also it is your second nature as well. Based on my experience, there are 3 factors leading to a good publication: reporting quality, methodological quality, and the topic. All these 3 factors are very important. However, I personally believe the most important one is the topic. Because if you write I don't know, the best a study or meta-analysis or any other study on with the best methodological quality and reporting quality on effect of aspirin in prevention of the myocardial infarction, so it is not necessarily what the literature needs. But if you do a good topic with average methodological and reporting quality, you're more likely to have the satisfactory outcome, because it's what literature needs. The former scenario, when you do a non-appropriate topic, inappropriate topic with a good methodological and reporting quality, unfortunately, what you usually receive from the editors in terms of decision is going to be this statement. So I give you a 15-second time to read this, and it is a common scenario that I have been facing, and so you might have been facing before, or people are more likely to face if they don't find the appropriate topic. The topic, therefore, I'm going to start with the topic. So the first things to that make the structure of your study is a topic that you are interested in. So the topic that you want to choose should not be necessarily interesting. It should be something that is within your specialty and what the literature needs that, as I mentioned. There are 2 ways of finding a topic. One is to ask, for example, an academic consultant who has got good publication history, who is aware of the hot topics in the area of the interest. And they can usually offer you some topics that you can do meta-analysis on. Or you can do it yourself by searching through the databases. Like PubMed is the one that usually the most publications usually go there, but there are others as well. I usually recommend latter, not the former. I mean the academic consultant, because sometimes it is their topics are good, but I'm yet to find a topic from a consultant who meets the following criteria. Because there are 4 indications to do a meta-analysis, and the consultant who offers you such a topic may not necessarily know about this. He or she may be aware that these are contraindication for a meta-analysis, but they don't necessarily know that the current literature, they are not orientated towards that. So number 1 is the most obvious one, is there is no meta-analysis on a specific topic. So if there is no meta-analysis on a topic that you have selected, and there are comparative studies on that, you can proceed with the meta-analysis. The second one is that, for example, there is a meta-analysis published on that topic. For example, I'm just making that up, laparoscopic versus open appendectomy, and it was done, I don't know, 5 years ago, but after that there are 4 or 5 new randomized control trials published, and then you can do an update meta-analysis on that. And that usually is well accepted by lots of journals, unless that topic has already closed, meaning that there is no need for further investigation for that topic. The third indication is having some fault in the previous meta-analyses. So for this one, you need to be an experienced meta-analyst to be able to pick up the problems with the other meta-analyses. Therefore, it is not something that, for example, you may take into account if you want to consider a topic for meta-analysis. And also the other one is to escalate the level of evidence. For example, the previous meta-analysis on this topic was a meta-analysis of only observational studies, meaning that they included cohort study and case control studies, and probably one randomized control trial as well. It was a mixed randomized and non-randomized studies. And then you after 2 years, you have got 2 more RCTs. Then you can escalate the level of evidence to level 1, meaning that you just include the randomized control trials. So the take-home message from this slide is that if you find a topic that there's no meta-analysis on it, or if there is a meta-analysis on it, make sure that there are different comparative studies on that so that you can do an update meta-analysis. The topic usually follows something is called PICO format. So PICO, you might have heard about this as well, is basically population of interest, intervention of interest, plus minus comparison of the interest, and condition of interest. And the last one is the outcome of interest. Your topic should consist of all these 4 factors, and I tell you what it means. So you can see that, for example, I've created a format for a topic, which is like effect of an intervention on an outcome compared to another intervention or no intervention in a specified population. So you can see that by such a performa, you have actually started to write your paper as well, because sometimes writing a title is difficult as well. But following this format, you can not only you start writing your paper with a title with a good reporting quality, but also you can include all those PICOs items in the title as well. I brought some example for you here. For example, effect of the whole body CT on mortality compared to the traditional diagnostics in trauma patients. I'm sure you should be able to correlate these factors together. The effect of the neuromuscular stimulation on incidence of VTE compared to chemical prophylaxis in hospitalized patients. Again, it's clear that what are the PICOs items there. So you can see that even this topic, for example, is not within the interest of surgeons necessarily, but you can see that you can critically appraise that title as well. You can see that whether it's informative or not based on the factors is there. It doesn't matter if it's in psychiatry or surgery. So that will improve your critical appraisal skills that usually start from the title by knowing how to do it. So therefore, in summary, you may need to just format your title based on the PICO format, and then just formulate one. After making a decision about your title or topic, it is usually good practice in meta-analysis to register your protocols. And I suggest you a website called Prospero, which is created by University of York. So it is an international registry for systematic review and meta-analysis. You basically go and log in or sign up, and then the rest of that is going to be very straightforward. So basically, you put the title of your proposed study, and then there are some boxes that you fill based on your methodology, and then after a few days they will register that for you. You've got a registration number. It enhances the quality of your paper, because some leading journals now, they want that registration number, or reviewers usually ask for it. For example, have you registered your protocol before, and what database, what registry have you used? It's not the end of the world if you don't have it, but it is something that create a good impression for reviewers when they have a look at your manuscript. The next step is search strategy. So you find a topic, you want to search for it to see how many studies you can identify to include in your meta-analysis. If you ask a librarian, for example, to give you a search strategy, he or she will provide with something like this, which seems to be very, very complicated. And based on my experience, most of the time, it doesn't give you the hits that you need. So my suggestion is to use much simpler form of a search strategy, and you can always make it look like this at the end when you want to write your paper. So the simple search strategy is consistent with the PICO format again. So condition of interest, intervention, population, and outcome. Sometimes you don't necessarily include all of them, just condition and intervention should be okay. But the most important point I would like to highlight here is to be familiar with the concept of or and. So we are going to go through some examples now so that it makes sense to you if you are not already aware of that. So, basically, you develop some keywords based on the PICO format. For example, if your condition of interest is appendicitis and your intervention of interest is laparoscopic appendicectomy, and your population of interest are people who have appendicitis, and then your outcome of interest are those that, for example, whether you're interested in post-operative complications or cost or whatever it is, you can apply it in any specialty in surgery. I just brought the example, or even in medicine. So let's go to an example for apologies in advance, because PubMed does not look like this nowadays, because the last few months they have just updated the website, but the principle is exactly the same, just the color and the place of the boxes are different, but the principle is exactly the same. So when you go to the PubMed, there is an option for you to do the advanced search. When you do that, you can see that there are other boxes up here. For any keyword that you use, you can always expand it. For example, say whole body CT, you can just mention CT as an abbreviation. You can put computer tomography. So it is the way that you can expand your search categories, basically each keyword, to ensure that you are given more papers and minimizes the risk of not missing important papers. And for example, say if it's your one of your intervention is beta blocker, you can use, for example, beta blocker here, but you can use, for example, put bisoprolol, atenolol, and so on and so on and so on, so that you can expand your search terms. And also you need to be mindful of the British and American spelling as well. For example, some words like embolization can be spelled by Z and S, so you can include both, because some journals are American based, some journals are British based. So the journals that are not necessarily in these two countries, they usually follow either English format. So by doing this, you can put boxes here with different basically synonyms, and it is important to use or between them. So not and. Or means that this or this or this. So basically it gives you the studies that has either this one or this one or this one, not necessarily all of them. So for each keyword, you do that and put or between them. You select in the drop-down menu, and then you add that to the history, which brings you a page like this. Whatever you have searched is going to be there for you, and then you're going to make a new classification for your keywords. For example, you've got a trauma, for example, you can put multi-trauma, you can put injury, and whatever you want to do, and then you put or between them as well, and then you add that to the history. It goes there for you. So now you have created two of your keywords that can be more based on the PICO format, but say two is enough for you, and then you just need to add them together. And to add them together, you need to use and this time, because you want the studies that tells you, want a study that tells you or include all these terms, or any of these and any of these. And then you put add them. When you put add them, they usually go to your search box again, and one by one, and then you select and option here, you search for it, and then it gives you the total number of hits. You can see that, for example, one keyword classification has given you around I don't know, 1 million papers. The other one has given you 600 whatever it is, and then when you add them together, so it gives you more restricted numbers, which includes your key terms. So that's about the search strategy. When you do that, when you develop your search strategy and you search it in via the multiple databases, the PubMed is the most common one, but based on the PRISMA guideline that I mentioned earlier today, so you should use multiple databases, but it is very unlikely that you have got a publication which has been cited in PubMed, is important publication that is cited elsewhere. You cannot find it in PubMed. So usually PubMed gives you everything. But the good practice is you search different databases. So the way that you exclude the papers, those 7,000 papers or 2,000 or 5,000 sounds a lot, but I guarantee to you that 98% of those can be excluded easily just by reading the title. So it is, you can say, oh, this is not relevant, this is not relevant, this is irrelevant, and if it's relevant, you read the abstract. A lot of them as well can be excluded by reading the abstract because of different reasons. For example, it was just like a non-comparative studies, or it was you were looking for randomized control trial. It wasn't a randomized study, but it was just a review. And then those can be excluded as well. Then you go to the full texts of, for example, now that any topic that you use, you're more likely to come with between 10 to 20 papers. Okay, so it could be more as well, but the new topics, usually you are unlikely to have a lot of papers on it, unless you are very creative to make a new topic yourself that you can include different types of studies. But I expect you to have around 20 30 studies, of which you can exclude several of them by reading the full text, because they are not, you can find them irrelevant as well. And at the end of the day, you include those that you think they are relevant. When you find your studies, then you say, for example, you have identified 10 comparative studies, say RCTs, for example, in this context, and then you just need to do data extraction. So the first step was very important for you because you have developed a topic, you search for it, you find the papers. That is very important step that you can easily do it successfully, but carefully, of course. And then the next step is to extract data from the papers. What kind of data to extract? Sometimes can be challenging for a person who looks at the study, because you may find the RCT has got 17 pages, and of course you cannot necessarily extract all details from that study. Most of them can be irrelevant. So I'm going to categorize this for you into 3 groups of data. One is called the study-related data. The second group are baseline demographic and study populations. And this third group are outcome data. The most important of which are outcome data, because it is the one that you analyze. Rest of them, you don't necessarily analyze them. But I'm going to bring some example for you. For example, if I have done a search strategy and I've identified 18 papers, for example, 18 we see the study design shortly. You usually put the name of the author, the first author of that study, in each row in the Excel sheet. And then you start to extract study-related data, which are very, very easy to pick up from each paper. For example, the year of publication, country of that the paper was published, journal, the type of a study design, clinical presentation or procedure performed. The latter two you can always amend. Okay, so because it depends on what you have in your study. When you fill it, it's going to be like this. Okay, so you can see the data is very easy to find out. So for example, the year you can easily find from the first page of the publication. The journal, of course, is even easier. The country of the publication, you can look at the affiliation of the first author. And then the study design. It could be a RCT, prospective observational study, or retrospective observational studies. Prospective observational studies are cohort studies. Retrospective can be cohort or case control, but you can group them as this. And then the clinical presentation as appropriate. So, but it is my suggestion. I noticed that after doing several publications, and then I noticed that I'm just repeating myself, or I don't have economy of movement, if you like surgery, for example. We say we need to have economy of movement. In this, you need to have economy of movement as well, because, for example, if you say RCT here and you put randomized control trial after that, and then put randomized studies on this, instead of saying all of them RCT, at the end of the day, you're going to copy and paste that, put in the Word document that makes one of the tables of your paper. If you do it tidy from the beginning, that extra work at the end of your project, when you are very excited to submit that, it just probably spoil your energy level, because you just need to adjust everything to make it homogeneous as well. So my suggestion is, if you do the data extraction, do it tidy from the beginning, everything to be very consistent in terms of wording, spelling, and the way that you have extracted data, so that at the end you can just copy and paste in your Word document. That can be a table one of your study. This is the study-related data, as simple as it is. You don't analyze them, you just demonstrate them by table. The second group are baseline and demographic data. For example, the same group of studies here, but there are some baseline characteristics that patient population have in each study that include age and gender, and also other comorbidities or factors are relevant to the topic. For example, assuming that this topic is about the effect of a statin versus no statin in patients undergoing vascular and endovascular surgery, some comorbidities are very important in this topic. For example, diabetes, hypertension, coronary artery disease, or a cerebrovascular disease. And then you need to extract data about that. But for example, if your topic is about colorectal cancer, for example, so for example, a stage of the disease is important, whether the patient received neoadjuvant chemotherapy, or where was the location of the tumors, as you may recognize. These factors are usually easy to pick up on the paper that you have selected, because they usually have got a table that shows you what baseline characteristics the study have. When you fill them, it's going to be like this. So you have got a study numbers, the sample size in each group, and then you have got your characteristics. And some studies, it is not your fault that they haven't reported this, but you just need to be clear that they haven't reported that. NR means not reported. And then you put, for example, the mean age of the patients in the statin group and the mean age of the patients in the no statin group. If they have reported, for example, a standard deviation as well, which is again not difficult to find, you can just put there. It is usually where they have reported this, they should have reported a standard deviation if they have. And if they have reported, you just need to just put it there. These p-values, you can put it there, you cannot put it there, it's up to you, or it's good to put them in, because sometimes it shows that, for example, in this study, for example, there was no difference in the mean age between a statin and no statin group, as reflected by the p-value of more than 0.5, is 0.29 here. So it means that the study population are in this group are homogeneous. But for example, in this group may not be in terms of the gender. So it just tells you, demonstrate whether the study population that you have included in your meta-analysis are basically homogeneous or not. As I said, you don't have to analyze this information. Recently, in the last 3 years, 2 years or so, I started to analyze this information in my meta-analyses, but I just want you to take this from now, that you don't have to analyze them. You just, again, like the table 1, you demonstrate them by table 2. So the message about being tidy on this also is very important, because you can just copy and paste it as your table 2. It is just based on characteristic, and these are usually very easy to find from the paper as well. They usually reported in a specific table in their study. However, the most important one are the outcome data, the ones that even you don't have the aforementioned data, by having the outcome data, you can do a meta-analysis. But before moving into that, I just need to describe 2 types of data for you, okay? Because we've got 2 types of data, and you need to be aware of that when you think of analysis of those. One is called dichotomous data, or categorical, meaning that, for example, the answer to that type of data or outcome is yes or no. For example, if you think of a post-operative MI, the MI has either happened or not happened, yes or no. So
Sorry, Shahin, we lost the voice. Shahin?
I'm back, yeah?
Okay, yeah.
Okay, and may I ask you, what was the last thing you heard?
It's with the starting of this data outcome.
Okay, sure. Let's start again here. So, so in terms of the back to my previous slide, outcome data. So they are before telling you how to extract the data with regards to them, it is important to know different types of data, okay? Because when you extract data, you need to be aware of this. So there are two types of data that you usually deal with. One is called dichotomous or categorical, and the second group is continuous. The dichotomous one are like yes and no. For example, if you are thinking of post-operative complication, and MI is one of those, the patient has either developed MI or has not developed MI. Your answer for that outcome is yes or no. It is called categorical data. The second group of data is continuous data. So continuous means that there is a value from 0 to whatever it is, for example, like height, or is making that more relevant to this to the surgical thing. For example, length of hospital stay is a continuous data that can be from 0 to unlimited period. So for each group, you need to extract different types of data. I'm going to bring you some example. Of course, it cannot be interactive using a webinar, but I'm just give you 2 seconds for each one to think, and then tell me, and then I'll tell you the answer. Mortality, is it a dichotomous data or continuous data? So I'm sure you have selected your answer now. So the answer for this is dichotomous, because the patient has either died or is alive. Okay, so yes or no. When it comes to the survival, do you think is a continuous or dichotomous? So it's other way around. This patient has already survived or not. So it's going to be dichotomous as well. How about a mean blood pressure? You can have mean blood pressure from 0 to 200. I hope none of you develop such a high blood pressure, but it can be continuous. How about the blood pressure between 140 to 160? So now in this, it can be confusing here, because you are talking about the continuous data, but you have defined a classification. For example, blood pressure between this or this, which means that the patient is either within this category or not. So this is a categorical data. Categorical means dichotomous, by the way. So a D-dimer level, so 0 to whatever it is, so it's going to be a continuous. Quality of life score 1, 2, 3, 4, 5. I wish the latter for all of you. So it's going to be continuous. And the serum glucose more than 11.1. So then it is a continuous data, but you have defined a category, and which means that you are either be within this category or not. So then therefore it can be a dichotomous data. And then post-operative complication, simple yes and no. And for dichotomous data, from the study that you're looking at, the study I'm talking about, for example, you have just a brief summary, you have identified 10 RCTs to include your meta-analysis. You are going to extract the data about the outcome, assuming that, for example, your topic is about the comparison of the laparoscopic versus open appendectomy, and your outcome is post-operative collection. So for dichotomous outcome, you need to say, is post-operative collection a dichotomous outcome or continuous outcome? It is dichotomous, isn't it? Because it's yes or no. And if the answer is yes, you need to have total number of events. In this example is collection, and total number of patients in your intervention group, which is laparoscopic group. You need to extract exactly the same figures from your comparison group, which is number of collections in your open group and total number of patients in the open group. Yeah, it may be confusing for you, but let me bring you some examples. For example, you're talking about the post-operative outcomes, MI and stroke. I'm sure you agree with me that MI and stroke are dichotomous outcomes, and your comparisons are, your intervention of interest is statins, your comparison of interest is no statins. Okay, so now in this study, the data that has been extracted is like this, meaning that there is 0 MI in 22 patients that were in the statin group versus 0 MI in the 8 patients that were in the no statin groups. Number of events in your intervention group, number of events in your comparison groups, and the total number of patients in that group. I'm just going to randomly jump on this one, a study of a stroke. It means that in the statin group, there were 228 strokes, and the total number of patients in statin groups were 654. And on the other hand, in the no statin group, you have 432 patients who developed a stroke, sadly, and 907 patients were included in the no statin groups. That is the only data you need to require from each outcome. If your study has got, if your meta-analysis, you want to look at 10 outcomes, you need to make 10 column like this, for example, MI, stroke, and extract the data according to that. When it comes to the continuous data, you need mean and standard deviation. It is not something that you calculate. This is something that the study that you have selected should offer you. So therefore, don't worry about the word standard deviation here, how to calculate it. They should report it for you. And if they haven't reported that, I tell you what would be the problem. So for continuous outcome, for example, the same research question, laparoscopic versus open appendectomy, one of your outcomes is, for example, procedure time. I'm sure you agree that procedure time is a continuous data. And if you want to compare these two, or at least include them in the meta-analysis, you need to have mean procedure time in the laparoscopy group plus minus a standard deviation versus the same numbers in the open group. As an example, here is the length of hospital stay of 20 studies that has been included in this meta-analysis. You can see that this study hasn't reported that. This study just reported mean and without a standard deviation, only one group. This one reported mean in both groups, but no standard deviation. But this one have reported mean and a standard deviation versus mean and a standard deviation in both groups. So it means that I can just include this one in analysis. I cannot include this one. I cannot include this one because I don't have a standard deviation. And of these 20 studies, for the analysis of length of hospital stay, I can include only 1, 2, 3, and 4 studies. These studies might have provided other data for your other outcomes, but for this outcome, only 4 studies. There are some studies that have reported the continuous data as median and range based on the normal distribution pathway, whether there was an outlier or not, but I don't make you confused. Just to let you know that there has been some continuous data reported as mean plus minus or in the bracket interquartile range. There are some equations that you can convert those to mean and a standard deviation. Is just like a calculator, and when it comes to that, you can always do that. But I just want to tell you that the software that do the analysis for meta-analysis only accepts mean and a standard deviation. Therefore, you need to aim for that. What is the indication for doing a meta-analysis, not for finding a conducting one in terms of the analysis itself? If you got more than 3 or 4 studies, you can do a meta-analysis on that. For example, even if you have identified 10 RCTs and 3 or 4 of them are reported one outcome, you can do. I say 3 or 4, I tell you why. Because sometimes the studies are not homogeneous. And if they're heterogeneous, if you do 3, probably that's the good excuse for reviewers to reject that paper with 3 only studies included. But for example, if you've got 3 randomized controlled trials or homogeneous, you can do 3. But in theory, more than 3, you can do a meaningful analysis. And but it depends on the basic heterogeneity among the included studies that you can determine 3 or 4. But as long as you've got 3, you can do that. So, for example, I'm just going to be bringing some examples. Length of hospital stay. Let me see whether I can do a meta-analysis on that. First of all, is it a continuous data or dichotomous data? Is it the continuous data? So I'm looking for mean and a standard deviation. How many of these studies reported what I'm looking for? 1, 2, 3, 4. So I can do a meta-analysis on this. How about pseudoaneurysm? Is it continuous or dichotomous? Is dichotomous or categorical. So I'm looking for number of events in each of the intervention group. Yes, I can include this. I cannot include that one. This, yes, that's more than 3. I can do that. But for example, how about this one, renal failure? First of all, is it continuous data or dichotomous? It is dichotomous because the patient has already developed renal failure or not. But there's only one study there, so therefore I cannot do a meta-analysis on that. Okay. So this process is called pilot testing, by the way, when you put all outcomes reported by one of your, by all of your studies, but you can see that there are some of them have been commonly reported. Therefore, you can ignore the others. So, but when you do the analysis, it's going to be very easy. The software, which is called Review Manager, it is the one that Cochrane has created. I think it's the best software for meta-analysis that is free to register, free to download, and this is the most transparent one. There are a lot of softwares. I don't recommend you use them because they are not as clear as RevMan. And if I review a paper, a meta-analysis, and then I see that they haven't reported the forest plot using a RevMan, and they use something that is not clear for me, I will always ask authors to revise them or reconduct the analysis using RevMan. So I recommend you to use RevMan for any meta-analysis. But it makes sense to you now. So if you feel this is going to be like this, for example, you know what these are. These are the studies that you have extracted. It's exactly similar to your data extraction sheet. You've got events and total in one intervention group and events and total in the other intervention group. And by putting these numbers, these will be automatically calculated by the software itself. And then the next step is your forest plot. So I move to forest plot. It is the outcome of the meta-analysis. I'm sure it makes sense to you now in terms of at least these numbers, okay? You can see that 4 studies included. This is exactly what you have put and extracted. They're easy to extract. Don't worry about the rest of them. We're going to talk about that shortly. In terms of the continuous data, that is why I said we need mean and standard deviation, because if you put 0 here, that will not be calculated. And unfortunately, there are a lot of meta-analyses. They put mean and median value here. They make up this number, putting number 1 or something like that. It is an erroneous meta-analysis. But to do the good practice, mean and a standard deviation, and if you have median with interquartile range, there's an equation, as I told you, you can convert that. So this makes sense to you now. So the same studies that you have included, you have put the mean and standard deviation, total number of patients in each group. It tells you whatever the forest plot requires, okay? So, and this is the continuous for continuous data. Now, what does forest plot mean? So the forest plot is the outcome of a meta-analysis that by doing all of your data extraction, everything, so you can just put the data in, it gives you this for each outcome of your study. And for each outcome, it is even if, for example, the meta-analysis, for example, is around 17 pages or 18 pages, and if you don't want to read the whole meta-analysis, if you look at the forest plot, you can tell, roughly speaking, what is the outcome of that meta-analysis. So I'm going to introduce only 4 elements in this in this forest plot that is all you need to be aware of, okay? This is, of course, is not part of the 4 elements. We have already introduced these 2. The first thing I want to introduce to you is something called here. Can you see risk ratio? So the risk ratio in the statistical term, it's called estimate of the effect size. Okay, it's basically a ratio telling you the ratio of the treatments that you have. For example, if the open appendectomy is associated with twice increased risk of intra-abdominal collection, for example, compared to open one, that ratio, for example, is expected to be 2. There are different terms for it. It's called risk ratio. The other one is called odds ratio, which is very different from the odds ratio or risk ratio that are reported usually in your randomized control trial or case control, a cohort study. But these are something that just belongs to the meta-analysis, just the ratio. The choice of them are controversial. I personally, if all of my studies are randomized control trials, I use risk ratio. If they are mixed or observational study, I use odds ratio. But sometimes you amend them based on the reviewer comments as well. But these are not yet more 4 elements. So what I'm going to tell you is this. For each study, the software has calculated a specific ratio, and there is a resultant ratio here, which is the calculation of all of those things based on the weight and whatever you don't need to be interested in. But there is a number here, 1.37, and there is a confidence intervals. I'm sure you have heard about confidence intervals. Confidence intervals is limit within which you are 95% confident that the true value lies. If your true value, for example, in this study is 1.90 here, there is a limit around that you're 95% confident that the value is within that one. That is called confidence intervals. Therefore, here, what you see is a confidence intervals. And this resultant odds ratio or risk ratio is reflected on your plot by a diamond, black diamond, okay? And in the plot, there are a central line, there is a treatment on the left side, there is a treatment on the right side. And in the adverse outcomes are means that they are bad outcomes. And for example, say this is a study which compared the placement of the drain versus no drain in liver resection. You know that for example, bile leak is a bad outcome, yeah? So therefore, in a adverse outcome like bile leak, you expect the treatment which is here, the drain, should be on the left side, and the treatment which is there, no drain, should be on the right side, okay? And the black square, black diamond, usually goes towards a treatment which has a lower number, means that in favor, and we know that in adverse outcome, lower number it is, more favorable the outcome it is, okay? It means that, for example, in this study, in this analysis of the bile leak, there is lower number of bile leak in no drain group compared to the drain group. Why I'm saying this? Because the black diamond is towards that, and I know that it goes towards the lower number, okay? And therefore, wherever it is in favor of that treatment. But there is something called a statistical significance. So yes, it is lower, but is it statistically significant? There are two ways of doing that. One is visual assessment, which can sometimes be unreliable in some circumstances. And there's an objective assessment. Visual assessment is when this diamond is clear from the central line, it means that that reduction is significant. If it is touching this, like for example this one, it means that there is no significant difference. The objective way of looking into that is looking into some value called p-value. We know that whatever statistical test you do, if the p-value is less than 0.05, that is statistically significant. And here you can see two p-values here. Ignore the one which is around heterogeneity, look at the one is around the overall effect. And you can see that the p-value is very low. It is consistent with your visual assessment, okay? So it means that, for example, if you want to report this meta-analysis, I would say in the analysis of bile leak, there were 1, 2, 3, 4, 5, 6 studies are included in the analysis of the bile leak. The analysis demonstrated that the avoidance of the drain was associated with significantly reduced risk of bile leak compared to using a drain in patients undergoing liver resection. Why I'm saying a statistical significance, I can usually provide this number, p-value, okay? And also you report this as well. Therefore, the first of those four elements I want you to concentrate on, number one was p-value, number two was reflection of that on the forest plot to see in favor of which treatment it is. Number three, was it significantly different? And number four is something called I-square, which is called degree of heterogeneity. So heterogeneity is bad. It means that higher it is, more biasful or less reliable are your results. There are different ways of categorizing that, but my personal categorization is this. If I-square between 0 to 25%, there is low heterogeneity among the included studies. If it is between 25 to 75%, there is moderate heterogeneity among the included studies. If it is more than 75%, it is significant heterogeneity among the included studies. It shows the degree of heterogeneity in your analysis. And I have to highlight, this is not within a study heterogeneity, it is a heterogeneity between the studies, among the studies. It doesn't tell you, for example, in this group, in this study, there was a heterogeneity among these two groups. It just tells you the heterogeneity among these studies based on the number that you have provided, okay? So this is the fourth element I would like to concentrate on. So if you're going to go and do another example, but before that, there's something called random effect analysis. And you can see there are some terms here written random. I go to the previous meta-analysis, says fixed. Okay, so there are two options when you do the analysis. So of course, doing the detailed analysis session is beyond the scope of this session, but I'm more than happy to organize one session for you if you are interested. So it's 45 minutes. I make you very, very orientated. So, but I tell you just the principle behind that. If your I-square is more than 50%, in the past you used to be advised to use random effect. If it was less than 12%, you used to use fixed effect model. But now the new guidelines saying that in the any surgical any topic involving a surgical intervention, there is an inherited heterogeneity among in the studies anyway, like the surgeon experience, the procedures, whatever it is. Therefore, you assume there is a high heterogeneity among the included studies. Therefore, you use random effect model always. Okay, so therefore, this should not be your headache anymore if you are doing a meta-analysis of the surgical research. Just random effect. So the other example, I just quickly go through that, probably I'm behind the time. So I just wanted to bring an example for you that there is no significant difference between two groups. For example, this is a comparison of the interrupted suturing versus continuous suturing in either bilock reconstruction. So you can see that easily. There are 1, 2, 3, 4, 5, 6, 1, 2, 3, 4, 5, 6, 7 studies included. You know what are these numbers? This is the total number of patients, all added together here. This is total number of events. They are added together here. If you want to, for example, calculate the rate of this outcome, for example, is let's call it biliary complications. So you can just, if you want to calculate the rate of biliary complication in this group, you can easily divide this by this. It gives you a rate. You can do this as well, but these are not what we are interested in the forest plot. We are interested in these results and ratio, which is odds ratio, and it means that in these studies are observational studies. That's why I use odds ratio, and it is a surgical research. That's why I use random effect, regardless of the degree of heterogeneity. So there is a results and odds ratio, which is reflected on the forest plot by a diamond. So you can see visually, and it is in favor of continuous, of course. It means that it is lower that complication continues. But is it statistically significant? The answer is no, because this is touching the line. So visually, I can easily say that, and also my p-value here is consistent with that. Okay, so it means that there is no significant difference in biliary complications between the interrupted and continuous group, and the degree of heterogeneity was the last element is 0. It means that there is a very low heterogeneity among the included studies. Okay, so and this is how you interpret the forest plot. Then you've got something called methodological quality assessment. You need to assess the methodology of your included studies, and you have got RCTs or observational studies. There are different checklists for it. So I usually use Cochrane tool for RCTs. Risk of, because the most recent one is risk of bias assessment tool one. And for observational studies, there are different Newcastle-Ottawa scale and sign checklists. The form is a bit outdated, but is relevant sometimes. But these are appropriate one to use. But as I said, the assessment of them are usually very easy based on there's a criteria. You can check it with your RCTs, but considering the time limitation here, unfortunately, I am not able to go through that with you, but it is what needs to be done. So, and then the outcome of that is like this. For example, it tells you what is the risk of bias in terms of, for example, selection bias, performance bias, and so on, so on. And it usually provides this graph for you. The same software does it for you. So Review Manager, which is for Cochrane. So my take-home message of 3 factors are important in publication: reporting quality, methodological quality, and topic. I'm talking about meta-analysis now specifically. The topic is the most important one because you can always improve methodological quality and reporting quality. And I want to highlight one more time, you can enter research and publication word in an uncontrolled way, knowing what be always these orientated, going through these studies and recruit yourself in these studies for data extraction. but I would suggest to enter in the controlled way when you do a highest level of evidence. And please do not hesitate to object or question a consultant, regardless of whatever degree of research or experience he or she has, and says that I'm not interested in meta-analysis, I'm not fan of that. Even they say this to you, you can say, please update yourself with the hierarchy of the level of evidence and realize that it is the highest level of evidence. No one can ignore that. And by doing this, you will be expert in knowing what elements are important in these studies. When you become a researcher, you can do one yourself as opposed to doing work for others. Okay, and that's it. So that's the end of my presentation. I hope you enjoyed that. I'm sure my colleague Sivesh has got also more important information for you as well. Okay, I'm more than happy to answer any question you have.
Thank you so much, Shahin. It's a very interesting topic and very well presented. If there is anyone who has any questions, we are available to answer him via the chat. Or you can make a reaction, a raised hand or something.
Yasmin, proceed.
Just a quick question, really. I mean, you've explained a lot of steps and a lot of searching and working through data. On average, how long does it take from developing an idea all the way to publishing? Because it sounds like a very long process.
It depends on the number of studies that you identify. So, for example, if you have your search has resulted, or you have identified, I don't know, 20 papers. So, of course, that make more time for you to extract the data. But there are some topics that you can identify only 5 studies. You can do it very quickly. But for a person who doesn't have the experience of scientific writing or hasn't done meta-analysis before, I would say the whole process maybe 2 to 3 months latest, if you spend not a huge amount of time, but a good amount of time on it. And your paper should be ready for a submission 2 to 3 months time. If you're more experienced, you can do it in 1 week. You can do it in, I've done meta-analysis in 3 days as well. So it depends on the level of experience. The actual process is not very complex at all. It's a bit workload is maybe the main concern. And I have to highlight, I forgot to mention it in my presentation, any step in meta-analysis, data extraction analysis, needs to be done by 2 independent authors, because I have no doubts in dealing with such a high level of data, high volume of data, you will make a mistake. I say you will make a mistake because I make mistake myself, and regardless of whatever experience I have in meta-analysis, and that mistake is very unlikely to be repeated by a second independent person who has got his own mistake, and then you sit together, you resolve discrepancies, and then that would be okay. But to answer your question, 2 to 3 months for a person who hasn't experienced that before. Doing the second and third one is going to be quicker. After 5 meta-analysis, you can do it in 2 weeks or 1 week, whatever.
Is that just the collection of data, or is that the whole process?
Whole process, including writing the paper.
That's very ambitious. I've been trying to get the meta-analysis through myself, and it's been many months. But
So,
I agree with you. It depends on how many papers you have, doesn't it?
So, Yasmin, when you say it has been taken for a few months, so probably it wasn't your priority. I'm saying that for a person who has got meta-analysis as his priority to get it done. So I will be very surprised if someone dealing with the data and spending probably 3 hours, 4 hours per week on data extraction, not being able to complete the whole process in 3 months' time. Of course, we all are very busy. We've got other commitments, post-on-call you cannot do. But I'm talking about the person who has got meta-analysis as a priority to do and has, of course, no much more commitments. And that can be done in 3 months' time. But I totally get your point.
Thank you.
No worries.
Anyone else has any questions? Okay, I really thank you, Shahin, one more time for a great presentation. The presentation is being recorded at the moment, and it will be available in the ESSGP YouTube channel. Okay, I think we can proceed now to go to Sivesh Hamarajah. He's a surgical trainee also, who is very experienced in publishing. Sivesh, you can unmute yourself.
Yeah, thanks, Ahmed, for inviting me. Let me just try and share my screen. Can you see this?
Yes.
Yeah. So I've been told to give a talk on how to write a paper and how to use sort of big data to collaborative research and hopefully over the next 20-30 minutes I'll be able to sort of just share with you some examples of how to write a paper which I've used and how I think moving forwards in the NHS that big data will be very key in sort of transforming healthcare that we deliver across the NHS. So I think, you know, when I first started writing a paper, I found it very complex, and I sort of said, actually, this takes a lot of time. And one of the things one of the academic surgeons told me was that it will often take you about 1 to 2 years from the time you sort of start a project to the time you finish writing a paper. And over the time that I've sort of written papers, it sometimes can take that long because, you know, you sort of start writing a paper, you go through several rounds of revisions, you send it to external authors to sort of give their input in that specialist area, and then you go through journals, and it might take some time because some journals might come back to you rejecting it straight away, and some journals might go through several rounds of revisions before they sort of accept your final draft and before it comes up onto PubMed. So the whole process is often lengthy, and one of the things I've learned is to actually persevere through that process, and it can be quite demoralizing at times. And I think that the key thing about writing a paper is to really think about what you're going to actually write in your paper. So you need to have a clear narrative of what the point you're trying to make. So Shahin has given you a really clear example as to, you know, how you go through the analysis and interpretation of the meta-analysis. And that's very important for you to understand that, because when you write the paper, all that level of detail should be simplified so that another surgeon, another patient, another clinician should be able to read that information without having to actually figure out the intricacies of the analysis that you've done. And a clear, concise paper is what helps you get the paper over the line and into the journals that you're trying to aim for. And the next few slides are some slides which Dr. Ibrahim has used. He's a renowned academic surgeon based in Michigan, and it's sort of the slides or sort of the paper he's written as what the template I've used to craft out all my papers that I've written. And it's really easy because it really summarizes what you have to write in a paper. So for instance, when you write, the first key thing before you start doing a paper is to think about your abstract, because that's pretty much a one-page summary. It can be as long as 250 to 300 words as to what your entire paper is going to be about. So when you're writing the abstract, you need to sort of have clear signposting of what the objectives are, what the background of the study is in 1 to 2 lines. You need to have 2 or 3 lines worth of methods, results, and conclusion. And the aim of writing the abstract is that it helps you improve not only your research question, but also helps you focus on what you're trying to write. And then once you submitted it, the abstract has another role of convincing the editors that it's worthy of a peer review. Because if you have a very clunky abstract and you have lots of waffly sentences around, people might often lose the plot. And what I try and still improve on is try and make it sound as punchy as possible. So for instance, you can be bold to say, for instance, if there is no evidence of prehabilitation in patients undergoing esophagectomies, you could say that whilst there is multiple cohort studies assessing prehab, there is no objective evidence for prehabilitation in the context of a randomized controlled trial. And that's a very powerful message, because We all know cohort studies has its flaws, but it's a very short, succinct line to use to tell the editors or the readers that actually this is a useful trial for it to be published in somewhere like Lancet or New England or wherever you may wish to publish the study in. And then the role of the abstract, again, is for when it gets published and when people read it. So it has three broad roles, and most people, most clinicians or patients reading your papers will only look at the abstract majority of the time. They will skim through the abstract. If they think it's worthy, then the people will proceed to go on to look at the results or the discussion. Because methodology, most of them are fairly standard, depending on if you do a systematic review. And big data can often be complex, so often there might be reviewers that might look at it, but we'll come to that later. So you need to make sure your abstract's really clear and punchy. The next thing is the introduction. And I always, again, when I first started writing, I was told to have 3 paragraphs in your introduction. The 3 paragraphs really helps to focus on what the key issues are. So in the first topic, you need to sort of give context to the introduction. You need to give context to what you're actually trying to do, because you have to remember that if you send out a paper for review, not many people, some might be patients who might not really understand what a total pancreatectomy might be, for instance. So you need to try and somehow navigate. It's a fine line between navigating between making it too simple but making it too complicated that no one can actually read it. And it goes through several rounds of revision. So you need to give context to what the study is about. And then you need to focus on why is the study important. So trying to demonstrate a clear knowledge gap. So for instance, if you're writing a systematic review, for instance, your clear knowledge gap would be actually there is a lot of published studies, being cohorts or being trials, that have reported different results. It might be in different directions in terms of the effect estimates that Shahin was talking about. And why the meta-analysis is important, it allows you to pull all the evidence to collate larger sample sizes to be able to draw meaningful conclusion. And then your third paragraph should focus on what are you intending to do. So you're intending to do a systematic review. And then in the same paragraph, you might actually also mention subset analysis, where you look at subset of the data to try and see whether there's some effect of what you're trying to look at. So it needs to be really clear and revise them as you go along. Now, the results really need to be clear. When I first started, I obviously didn't know how to write, and I sort of wrote a lot. I wrote a lot, and I had several rounds of revisions to be able to summarize and succinctly say the results clearly, because it's easy to sort of talk about a lot of different things, and you might get lost in the whole data, especially if it's big data. So what I always start is I start by laying out the tables and figures for me to get a flavor of what the data actually shows, be it a systematic review, be it a cohort study, and even a randomized control trial. So laying out what your key tables and figures helps you really map out what your results are going to be, and also helps you with the discussion. And sometimes what I quite like to do is I quite like to signpost each paragraph. So for instance, if I'm doing a cohort study, I quite like to say a first paragraph on patient demographics, and I sort of signpost it as patient demographics on the top, and then a chunk of results. And then I might move on to describing risk factors associated with outcomes in a multivariable model. And then I move on to sort of signpost it to overall survival. So for instance, just say if I'm writing a paper on anastomotic leaks on survival after esophagectomy, I would focus my first paragraph on baseline differences between patients with and without leaks. And then I move on to describing risk factors associated with leaks. And I then move on to describe how these patients developing leaks have poor or better or similar survival, etc., depending on what your data shows. And you need to and the key thing to writing a paper is to be able to go through the paper several rounds of revision by yourselves, with your supervisors, or even with external experts, because they always bring in a different eagle eye of for the paper. And discussion is where it brings it all together. And again, for discussion, I have a very rigid way of doing it. Again, the same way as Dr. Ibrahim used to say, where your first paragraph really summarizes the key findings. So you sort of say, this study included X amount of patients demonstrating X, Y, and Z. And then you have to try and draw how is it that some of these studies actually, or why is it this cohort study is relevant to the research gap that you've put forth in the introduction. And then you need to have 1 or 2 paragraphs to then describe what your findings are. So for instance, you need to be able to say, okay, so just say if you say anastomotic leaks doesn't affect survival, you need to try and explain that, because that's something a reviewer might pick up on. Or if you do subset analysis, you need to be able to have a separate paragraph to describe that. So it's about thinking through what your results show and trying to find the evidence to support that. And also you need to another paragraph on recognizing limitations and strengths and limitations. Every study will have a strengths and limitations, that's for sure. And there is no study without any limitations, because that never happens. Even though you might have delivered the best randomized controlled trial, you might need to think about areas where you might have biases that might affect the findings of the trials. And what I sometimes find useful is when I sort of tabulate the results and figures, I try and think about, okay, what does the data show? Where might be the potential differences or limitations, which I can then come to when I write the paper. And also you need to think about what does your results have implication-wise in terms of the research moving forward. So if you do a cohort study, if you say actually leaks affect long-term survival, your implication might say future research should focus on reducing anastomotic leaks after esophagectomy in a randomized controlled trial, something like that. And it allows people, it not only it's punchy, but also allows people to actually say there is a relevance. You've identified the knowledge gap, you demonstrated that in your findings, and you're thinking of your next steps. And that is what gets a paper published in the domain. So that's just about writing a paper. And one of the things about writing a paper that I learned is through actually being involved in collaborative studies. And collaborative studies, as we know, has moved quite a lot in actually changing the way we actually look at data and we publish data. And traditional research models will often sort of suggest that, you know, you've got single center studies, you have 20 patients at each individual center and you publish. And we know that a lot of single center studies, be it cohort studies or trials, are very much underpowered, and it's unlikely to demonstrate any meaningful differences for patients. And this is where we have sort of moved towards is actually being more patient focused. So we move towards a collaborative research model and gathering big data, which is validated, and it gives you large numbers to be able to actually bring up new hypotheses that you can test in interventional trials. And the reason for having cohort studies is it improves generalizability. You know what's going on across the UK or even the globe. And I'll sort of bring on examples that we've been involved in delivering cohort studies. And the benefits of collaborative studies is for all trainees. If you're here, you know, you sort of get an understanding about how to deliver audit and research in local facilities. And for those in the UK, CCT will move away from just top line authorships in either case reports or local studies, and moving towards more being associate PI schemes, which are funded by the NHR. So if you're involved in those sort of studies as an associate PI, that will count towards your CCT rather than just having 3 papers at the end of it. And also there's fair equal accreditation, because we don't have any top line authors, especially when we sort of do it from the West Midlands Collaborative or other associate collaboratives from Birmingham. So I think when people think about collaborative research, you sort of go through a phase where, oh my God, what do I do? Because it's quite a lot of work. And actually in the UK, not only just in Birmingham, there's been a massive growth in trainee research networks. And it was started initially in the West Midlands by some surgical trainees who are now consultants, where they've delivered randomized controlled trials and high quality research to be able to be practice changing. And that was trainee delivered, and it shifts away from the consultant focus over him training to demonstrate that trainees are capable of delivering high quality studies under good supervision and mentorship. And from there, there's been a lot of collaborative research that has been formed. And then if we look at why big data is important, is because you gather so much data and it involves a lot of surgeons, clinicians, patients actually in the heart of it to be able to actually bring meaningful discussions. And these are some of the studies that have been done by West Midlands or the European Society of Coloproctology. And these are just some of the collaborative research which I've been involved in to different extents. Some are medical student training led, and some of them are postgraduate training led, which I'll sort of talk to on a couple just to get you a flavor and highlight hopefully the importance of why collaborative research is important, especially in the NHS, and how we can go about doing it. And I'm sure that you know that the long-term strategic priorities of the NHS is actually improving long-term outcomes in patients who are multimorbid, and we will see a lot of patients who are deemed high risk surgically. And to be able to address these patients, there's a lot of funding going into health data science and big data. So StarSearch is something that some of you might have heard. It was established by trainees and medical students in 2013, and it's supported by the BJS to empower and advocate students to develop and demonstrate academic and leadership skills. And often we think that medical students or trainees are not able to deliver research, but actually over time, over the last decade or so, we've demonstrated that, and I'll explain how we've demonstrated that. And the key thing is structural organization. And when you sort of in large networks of teams, you need to have clear structure. In StarSearch, we have students at the core of it, where they're collaborators together with trainees, be it surgical trainees and perioperative care trainees, involved in collecting data and validating the data they collected. And then above them, you've got students who are regional leads. And over the last 5-6 years of me being involved in StarSearch, you know, there's a lot of capable students who are really able to deliver these studies across the regions in Birmingham and across Edinburgh and all the medical schools that you've got. So we normally have 30 to 40 regional leads. And at the very top, you've got the steering committee, which you've got a good representation of 60-70% being students across the UK. And the current committee, we have about 15. And only myself and other trainee are sort of not medical students. And it just really shows that there are really broad skills to upskill these group of trainees. And all of you here today are able to be involved in cohort studies. So one of the things that we wanted to ask not long ago was about esophagectomies. Now, esophagectomies are a complex operation, as some of you will know. It's associated with high risk, high morbidity, especially in anastomotic leaks, where it's associated with prolonged length of stay, poor quality of life over long term. So one of the things that we want to do is do an international prospective cohort study to include all cancers from April to December 2018. And we sort of developed an online standardized data collection tool called RedCap. And we had clear guidelines about what the anastomotic leak rates should be based on the Upper GI Association based in the UK, and what the benchmarking 30-day and 90-day mortality should be. And these, you need to have clear guidance from the outset before you start a cohort study to collect big data, so that people don't get confused as to what you're looking at. And obviously we had clear outcome definitions on anastomotic leaks. And actually this was quite surprising because we've never really done, you know, esophagectomy is a very niche area, and you know, you really need large numbers to be able to draw anything meaningful. And we sort of proved ourselves wrong by having 142 centers across 41 countries. It might seem actually not that much, but actually the amount of organization for you to go to be able to network, communicate, and support all these centers, it takes a lot of time, a lot of effort. But we build a network for us to then move forwards when we think about actually changing outcomes of these patients. And we often think at a center level, how can we improve our patients? But actually doing broad cohort studies, trials, informs you how we can actually improve global outcomes, especially in centers where resources might not be well available, and trying to support and help improve outcomes globally. So we included almost 2,200 patients, 673 collaborators from 43 countries. And one of the things that we wanted to gather is trying to gather how we can actually use a survey to understand how surgical practices in each of these centers vary. And you know, one of the key principles of donor opinion is that if you want to improve the outcomes of patients, you really need to understand the structures and processes that go within. We all sort of really look at surgeon volume and hospital volume, but that only affects what happens within the operating theatre. A lot of it on improving long-term outcomes for patients largely goes on to improving the preoperative and post-operative phase, and also the treatment pathway. And if any one of you have seen the last 5 decades of changes in long-term outcomes of cancers, you can see bowel cancer, breast cancer, and even melanoma really seeing greatest differences. And why is that? It's not about improving surgical technique. It's about improving your perioperative pathways and the overall cancer care that they receive. And that's something that we are keen to look at within OG cancers from a global perspective, because the differences over the last 5 decades have been fairly minimal for all comers. So then once you do a cohort study, you need to publish, because everyone will sort of start asking you what happens once you finish this cohort study. So we had our first paper in analysis surgery reporting the anastomotic complications and the management. And one of the things that we found is that actually there are quite varied management pathways and they're not standardized. And that's a key area for us to target. And how can we really improve that? We're not going to be able to derive whether if stents are going to improve outcomes or if we're going to have endosponges, but actually having bundled pathways might really help tailor outcomes in these patients. Or we could take a step back and how can we risk stratify and optimize these high-risk patients before surgery. Then we wanted to look at what are patients across the globe doing. And what we found is that patients in low middle income settings have almost 2 to 3-fold higher risk of mortality at 90 days compared to patients having esophagectomies for cancers. And when we mapped them out to the hospital level survey, we found there are differences between the availability of radiology on calls, surgical on calls, or the surgeons covering 24-hour on calls, or availability of ERAS programs that really led to differences in mortality. And this is another example of how it's actually hypothesis driving when you do the studies. And obviously, as we said, we have clear authorship criteria. Everyone's recognized on the top. And again, you can see everyone cited, there's no named authors on the top. And that's just an example of why I think collaborative research should be the mainstay of trainees moving forwards. And then we have to understand how can we reduce and prioritize anastomotic leaks. It is a problem. We still have no strong, good trials actually to reduce anastomotic leak rates, and everyone's doing something different. I think moving forward as a community of surgeons, and not surgeons actually, just even oncologists, clinicians, everyone should be focusing on how can we really improve care of these patients with urgent cancers, and doing a global study on prioritization really helps narrow our focus. And we really found key areas where we should be prioritizing that we're keen to work on and develop as we move forwards in improving global cancer care in patients with esophageal cancers. And again, what does it cost? It's actually not expensive. We had RedCap at the courtesy of the Birmingham Clinical Trials Unit, which we have really good support with, and also from the charity. But moving forwards, we're thinking of funding opportunities to be able to sustain such programs. And obviously, you need a very big team to deliver this. It's not a single individual's effort. And this is a training collaborative, and it's done really well with multiple presentations and publications. And the last thing to finish off is students. So that was a trainee-led approach. This is a student. And STAR study, which I talked to you about over the last decade or so. We've done a lot of cohort studies, and it is very much across the perioperative pathway. So OAKS was focused on acute kidney injury. Recon was very much focused about pulmonary complications. And we've had several publications, some including in the Lancet Digital Health recently, and these are all student-led research, which are high quality. And one of the ongoing projects which I've just finished, which I've just led with STAR Search, is Cascade. And what's the rationale of this? Well, major abdominal surgery is increasingly common. As we have the increasing waiting lists, surgery will become the forefront of treatable disease moving forward. And cardiovascular complications aren't very common. Cohort studies have sort of demonstrated to be about 5% and 47%. So it's quite variation. And partly the reason is the lack of what we define as cardiovascular complications. But you might ask, why is cardiovascular complications so important? There's a recent Lancet paper that's demonstrated that if you look at the global burden of disease, post-operative deaths account for the third most common cause of death. And it's not to say that we're doing harm to our patients, it's that post-operative mortality is actually an issue that we've not really addressed globally. And about half of these mortality are attributed to cardiovascular complications. So whilst it might not be as common, it is actually accounts for 50% of deaths globally, which means that it's a key area for targeting interventions. So we sort of set out to run a cohort study to try and define the rates of complications based on this new recent guidance from perioperative consultants across the globe. And we identified gaps. We said we wanted up-to-date evidence on benchmarking rates so that we can use them for trials. And we need to understand how can we use these cohort studies to assess clinical practice to improve current evidence base across Europe and the UK in preventing and management of post-operative cardiovascular complications. and also identify risk factors to contribute in further RCTs. And once we're able to identify what the different interventions might be and the estimate size of these interventions, we'll be able to then better inform preoperative guidelines moving forwards. And this is just an outdated slide, but we've collected about 25,000 patients across UK and Europe over the last 6 months, and about more than 400 countries across UK and Europe. And we've had broad representations for preoperative consultants and also surgeons. And we're sort of in the stage of analyzing the data, and hopefully we'll have some more data to share. But hopefully I've sort of convinced you that actually collaborative research, big data is the way forward, and it'll hopefully transform how we risk stratify patients, high-risk patients, and try and identify high-risk groups to optimize them preoperatively, postoperatively, and hopefully all of you will find that useful and moving forwards in your career. Thank you.
Thank you so much, Sivesh. It's a very interesting talk about the big data and the collaborative studies and how to publish paper in general. If there is anyone who has any questions, you can raise your hand or write it in the chat box. Any questions? Do you need to have a senior author to get published? That's a good question.
No, so actually, the way we've always worked it is, depending on whether it's postgraduate or student-led. So with Star Search, it's often the steering committee. And so for instance, this year, doing as a lead for Star Search, I've been the senior author, but we've had good support from external advisory groups, which are consultants, consultant surgeons, and NESTIS, who give you strong mentorship, and it really is a source for upskilling. So you don't need to be a senior author. You just need strong mentorship and support when you go through the process.
Okay, so you can publish by yourself, but you just need someone to supervise you from like a senior person or who's experienced.
Yeah, and I think it's useful from that because they give you different perspectives, especially when you craft out the protocol, when you disseminate the study, because there will be a lot of experts around. So for instance, cardiovascular complications, there's a lot of experts in London, across the world, and you want them to give them input. So when you build the protocol, and even when you publish the studies, there's a lot of nuances within the data that they will see that you might not quite appreciate as a junior, but that helps craft it. And it's your role as a senior author to be able to navigate through those comments and see which is important, how to improve them, and then bring it back to them. So it's all a sort of skill managing wide network of people. Okay.
Another question is how do you choose which journal to submit to?
So there's an interesting question. So when I first started writing a paper, I always try and go somewhere high, and often the senior authors, if you're sort of writing a paper by yourself or even collaborative research, you often try and see what the data looks like, the final product looks at the end. And then you often, if it looks really good, it's worth a punt, then you can try and aim for somewhere high. So for instance, some of the COVID search studies have published really well in Lancet, and because it was an important need at that point with COVID-19 and patients undergoing surgery, so there was no studies on that. And that was pretty much the first study, so it published really well in Lancet. So I think it really depends on the landscape, what the current evidence are, and how it normally fits the impact. So it's a lot of trial and error. No one gets it right the first time.
Mm-hmm.
You can try and go the lowest in your first attempt, but I probably wouldn't advise that. So take advice from your consultants and seniors first.
Okay. Any further questions? Okay. I do thank both of you. It's a great talk from Shahin and Sivesh, and thank you for all the audience who attended this talk. And thank you for the ESSGP community. It's for organizing this. Thank you.
I think we'll wrap up the session then, Ahmed, don't you think? The video should be available. Give us just some time to edit it, and then you can access it through our YouTube channel. I've put the link in the chat box.
Okay. Thank you so much, Yasmin, for this.
No worries. Thanks for organizing.
Bye.
Have a good weekend, guys.
You too.